Welcome everybody. It's my pleasure to be speaking on diabetic eye disease tonight. For those of you who do not know me, I'm Jenny Ip. My special interest is medical retina. So managing patients with diabetes, and in particular those with diabetic eye disease, we should be aware that the majority of our patients do report some form of visual impairment that makes everyday activities quite difficult. It's quite concerning that a fifth of our patients do have visual impairment sufficiently bad to impact on the ability to manage diabetes, and a very significant proportion, in fact a fifth of them, have never had an eye exam. 1 in 10 patients with diabetes will have vision-threatening complications. These include macular edema, vitreous hemorrhage, as you can see on the right-hand side, a neovascularization, or the development of small, tiny, fragile blood vessels that then ultimately, untreated, can lead to tractional retinal detachment, as you can see on the bottom right-hand corner. This gentleman is a 71-year-old male who is quite typical, probably, of patients who may walk into your clinic or into my clinic. He's a truck driver. His diabetes was diagnosed a few years ago. He says that he regularly checks his blood sugar and reports that his last BSL was 7.2. He doesn't know his last HbA1c, but tells you that he smokes about 15 cigarettes a day. What you see on the scans here are OCT scans, of course, and in black and white you see the profile of both macula, the right eye and the left eye, and then you get the color map, again showing you the extent of any macular edema. In both eyes there are red areas surrounding the center, indicating that there is non-central macular edema. He's got fairly reasonable visual acuity of 6.9 and 6.12, and he has moderate to severe non-proliferative diabetic retinopathy. But because there is macular edema close to the center, he was told to return about 3 months later for another review. And in fact, he returns 9 months later, and the reason is because that he can no longer read the newspaper now. And you can see why, because visual acuity in that left eye has dropped to 660. There is gross macular edema. The map tells you that it's all central involving, and it's colored white, which tells you that it's quite a lot of severe and extensive macular edema. What we should understand is that for a lot of patients with diabetes, they're less likely to be compliant if they have good visual acuity, and those who have less severe diabetic retinopathy are also less likely to adhere to medical advice. For patients with macular edema, there is variability in appointment attendance, which then can affect treatment and treatment effectiveness. Coming and adhering for eye injections, again, there's quite a range of variability, up to 85% come, but as high as 30% don't come. And we often lose them to follow. About 25% don't come back at 12 months. So at the time of any diabetic eye disease diagnosis, this can be a very pivotal moment, and for a lot of our patients, it can be a critical wake-up call. This is a good time, it's a critical time for eye care professionals in particular to educate patients so that they can maintain lifelong healthier habits. The things that we should be telling our patients, of course, glycemic control, the HbA1c is important, but also variability in fasting blood sugar levels. Continuous glucose monitoring is becoming more popular now, and the time in range on these continuous glucose monitors can impact on, or can be an indicator of how good their glycemic control is. For people who have also hypertension, reducing their hypertension or improving hypertension control can result in 30% reduction in retinopathy. Obesity, the ratio of your waist to hip The higher the ratio, the higher the risk of retinopathy. Lowering cholesterol levels and lipid profiles will improve diabetic retinopathy. Exercise, increasing by 10 minutes a day of moderate to intense exercise can result in up to 75% reduction in retinopathy risk. The smoking, of course, is associated with higher odds of complications. Having retinopathy is linked to a higher risk of renal damage, peripheral nerve damage, cardiac, autonomic neuropathy. We're finding increasingly to obstructive sleep apnea in the presence of people with diabetes can be associated with higher rate of retinopathy. And of course, pregnancy can worsen retinopathy. So this gentleman, like a lot of our patients with diabetic macular edema, was treated with anti-VEGF injections. VEGF is a critical regulator of angiogenesis or blood vessel growth in the eye, and also affects the permeability of blood vessels. So this is a critical target in treating diabetic macular edema. What you can see on the top row there is the patient's starting macular appearance, and this improves gradually with repeat treatment. He had 4 weekly injections in the 2 eyes, and this over a 3-month period substantially improved the macular edema bilaterally. Not only is VEGF increased in macular edema, we know that there are high levels of VEGF in patients with proliferative diabetic retinopathy. So on the x-axis, you can see that there are 3 groups for comparison: the control group, patients with inactive proliferative diabetic retinopathy, and also active proliferative diabetic retinopathy. The levels of VEGF are indicated in the light blue, and you can see on the y-axis on the right-hand side that it's significantly higher in patients with active proliferative diabetic retinopathy. VEGF is placental growth factor, and it's also elevated in proliferative diabetic retinopathy. So increasingly, we are treating patients with proliferative diabetic retinopathy with anti-VEGF injections as well. What you see here is a patient who had previously had retinal laser in the right eye and had quite erratic glycemic control. The arrow there indicates an area of active neovascularization. And so she went on to have a combination of anti-VEGF injections as well as more retinal laser. And after combining these treatments for a period of 2 months, you can now see that the neovascularization has consolidated and condensed to fibrous tissue, indicating it's now inactive. You can also see those fresh retinal laser spots in white. And the reason why we treat these areas of neovascularization is that you really want to prevent a big bleed, as you can see in this patient here. So on the left-hand side, the black and white photo indicates an area of active new vessels in the temporal macula, and this went on to bleed quite substantially. It was very, very close to the fovea, and took many, many months to resolve, as well as a lot of anti-VEGF injections. In the time of COVID, and also in patients who are already less likely to comply with medical advice, we really shouldn't tell our patients not to take their vision for granted, and to encourage them to come for their regular diabetic eye checks, even if they have no symptoms whatsoever. This was a 35-year-old father of 3 who had 6/6 vision and had diabetes since forever. He was on insulin. But in fact, he had quite florid neovascularization at the optic disc. And he had quite a lot of retinal laser treatment in both eyes, but still went on to have a vitreous hemorrhage in that right eye and required anti-VEGF injections as well. So to summarize, our current mainstays of treatment for diabetic eye disease include glycemic control, general health, regular monitoring, injections in the form of anti-VEGF, steroids are sometimes used, as well as retinal laser. What we're looking at for potential future treatments include a newer class of drugs faricimab for treatment of diabetic macular edema has just completed phase 3 with year 1 results available, so they're very promising. There's more and more talk about diabetic neurovascular degeneration and protective agents, and hopefully we'll be able to speak about gene therapy in the not too near distant future. Thank you.